My name's Jaqueline Andrews. It says from my slide I'm a rheumatologist based up at JA EDITED. And usually the first challenge for rheumatologists is, what on earth is rheumatology? Does anyone know what rheumatology is? Or any of you rheumatology patients? Does anyone want to put their hand up to volunteer? Here we go. Here's the brave lady at the front. Do you know what the study of rheumatology is? Absolutely, musculoskeletal diseases, but a kind of broader specialty than that as well. So what is rheumatology? What do rheumatologists do? Well, we mainly deal with problems caused by disorders of the immune system, known as autoimmune disorders. And these conditions are much more common in females, particularly of childbearing age, so between the ages of sort of 20 and 40, or when a lot of rheumatological conditions develop. Immune system, of course, is a system that spreads throughout the body, so if you have a problem with it, it can affect any organ in the body. But as the lady said, often autoimmune conditions cause problems of the musculoskeletal system, so that's joints, muscles, tendons, soft tissues. But these conditions can also affect other organs, particularly things like the lungs, the nervous system, and the kidneys. So we like to see ourselves as rheumatologists really as last bastion of general physicians, in that we don't just look after a heart or a kidney, we look after all the organs in the body because the immune system has a very wide-reaching effect everywhere. As well as the immune problems, we also look after people with more mechanical joint problems, such as osteoarthritis. But increasingly, rheumatology is becoming an immunology-based specialty, whereas mechanical joint problems are mainly managed in primary care or through physiotherapy, or if it can't be managed with those specialties, by our orthopedic surgeons. So people are often still referred to us with mechanical joint problems, but often we make the diagnosis and make sure it's not something to do with the immune system, and then perhaps pass back to better equipped people to deal with it. So we have changed a little bit. In the old days, people used to remember everything in rheumatology in the region was in Harrogate at the Spa Hospital, and that was the treatment of rheumatology, taking the waters, etc. It's very, very different now. And one of the really big changes in rheumatology over the last 20 years has caused our little specialty to go from a minnow to being an absolute monster in terms particularly of drug costs, where for a long time the treatments of rheumatological conditions were things like aspirin and gold and really very old-fashioned things, to really being state-of-the-art treatment with these drugs called biologics or magic bullets, which has revolutionised, thankfully, the treatment of rheumatological conditions. More on that later. So a little bit about us at Leeds Teaching Hospitals. We're very proud of our rheumatology centre in Leeds. We're an extremely large rheumatology centre, and we're probably one of the biggest centres, not only in UK, but in Europe. And we're a very research active centre, and we're part of what we call the EULAR, which is the European Rheumatology Society Network. And we're very pleased that we've been given Centre of Excellence status since 2005. So various criteria have to be met to be called a Centre of Excellence. We're mainly based up at JA EDITED. Well, initially we were in Harrogate, the Spa Hospital. Then we went to the LGI, and about 10 years ago, JA EDITED was revamped and we moved up there. And we have an inpatient ward in Ward C2 at JA EDITED, which is a 20-bedded unit shared with dermatology, who moved up a couple of years ago from LGI. We have a really big daycare unit because, of course, this explosion of these drugs called biologics, a lot of them are given intravenously. So we do that in a daycare setting. We have about 5,000 patients a year who pass through the daycare unit. We have, it's a very outpatient-based specialty, and we have about 25,000 patients a year who come to our outpatients. JA EDITED, I don't know how many of you have been there, but we love it. It's a great little hospital, and we have a lot of shared resources there with other therapists like physiotherapy. We have a hydrotherapy pool, occupational therapy, podiatry, that's foot specialists, and our research facilities are there too. So it really is the hub of rheumatology in the city. However, we do have beds elsewhere. At St James's Hospital, we have inpatient beds, so our very poorly patients go there because they have all the backup of an acute hospital setting that they need. And we also run some outpatient clinics at St James's too. At Wharfdale, we also have some outpatient clinics. We were at Seacroft until recently, but we've mainly moved over to Wharfdale. So we're a really big department. At last head count, there was over 100 people in our department. And this is a photo of us on a rare sunny summer day at Chapel Allerton. And just to give you a bit of a who's who, unfortunately they're all names, I haven't got any photos for you. So I'm Jaqueline Andrews, I'm the clinical director. What does that mean? Well, it means I'm a rheumatologist, but it means I'm also a medical manager as well. So I was the lead clinician for rheumatology for a few years, and a few years ago I became the clinical director for the whole hospital. So that's rheumatology, dermatology, and orthopedics, all based at Chapel Allerton. So I have two hats. One is being a doctor and looking after my patients, and one is making sure the services run as efficiently as they can on the site. Our head of nursing is Zoe Kirk, who's a very experienced senior nurse who manages Chapel Allerton and also Wharfdale Hospital. Our lead clinician, so she leads the rheumatology patch, is Jane Freeston, and our business manager, Rob Guest. So on a day-to-day basis, we are the four that are running the rheumatology department from a management point of view. So any problems, we're the people that try and sort things out. Okay, so we have 16 rheumatology consultants now. We're pretty huge, and I've kind of split them up in that myself and Jane and these four here, we're what we call NHS consultants. So our contract is to do clinical work, look after patients. And then we have all these other consultants here who are also fully trained rheumatologists, but they are academic rheumatologists. So their main remit is to do research. And I think it shows you what a big research department it is that we have more research rheumatologists than we have NHS rheumatologists. So they might spend half of their week looking after patients and half of their week doing research. And you probably know some, I don't know how many of you are rheumatology patients, but you probably know some names there. Professor Paul Emery is one of the world's leading academic rheumatologists. He and a few others around the globe have really changed the face of rheumatology in the last decade or so. And a lot of the research that's come out of the Leeds department has been run by Paul and his team, and a lot of it is around the biologics treatment. If anyone has a burning question, just shout out, but I'm very happy to take questions at the end. But if there's something you don't understand as I go along, just stick your hand up. But obviously it's not just about rheumatology consultants, it's a huge multidisciplinary team in rheumatology, particularly because so many different organs can be involved. So we have a number of rheumatology nurse specialists. We have a very big training centre. We have lots of rheumatologists in training. We have what we call allied health professionals. That's physiotherapists, occupational therapists, psychologists. We have pharmacists who deal especially with these drugs, and obviously the research team as well. So what do we manage? Some of the struggle with what a rheumatologist does is we do cover quite a large patch, but often the conditions are quite rare. And what it really burns down to is that we manage arthritis, which is just a word to describe problems with joints, certain autoimmune diseases, and also the more mechanical joint problems and this condition called osteoporosis, thinning of the bones. Some of the confusion with rheumatology is based on the terminology. So I spend a lot of time in clinic trying to explain to patients that the words that have been given all mean the same thing. So osteoarthritis, degenerative arthritis, rheumatism, they basically are all describing the same thing, and osteoarthritis is the proper word for it, which is something unfortunately we all get as we get older, but some people get it, are programmed to get it at a much younger age, usually genetic elements to it. And so again, we're doing quite a lot of work in Leeds looking at treatments for osteoarthritis, but it's a bit behind treatments for immune diseases, unfortunately. So the bulk of my work as a rheumatologist on a day-to-day basis is looking at people with inflammatory arthritis. And there's, again, lots and lots of different types of inflammatory arthritis, but by far the most common one, and you probably all have heard of, is rheumatoid arthritis. And again, we spend a lot of time educating patients that osteoarthritis and rheumatoid arthritis are absolutely polar opposites. They're completely different things. Where rheumatoid arthritis is a medical condition caused by a problem of the immune system, where the immune system has gone a bit haywire and it started to cause inflammation in the joints, and the joints become red and hot and swollen. And lots of people think arthritis, oh, that's a condition of old people, why bother? But rheumatoid arthritis is a condition that can affect, babies through any time, of your life. And some of the really heartbreaking cases are seeing children with rheumatoid arthritis. But again, it's a good news story. The treatments are so much better now, and we treat people very early and hopefully get them into remission at a much earlier stage. And then there's a lot of overlap with other kinds of inflammatory arthritis. So people with psoriasis, the skin disorder, can have problems with their joints too. You might have heard of this thing called ankylosing spondylitis, which is an inflammation of the spine, more common in men. And gout is a cause of inflammation in the joints too. So anything that causes inflammation in joints, I'm your woman. And then there's the kind of slightly more weird and wonderful conditions called connective tissue disorders. And though they're rare, they can have quite a significant impact on people that develop them. And again, unfortunately, they're more common in women, so we think there must be a hormone element to it too. None of them are common, but the most common one is this condition called SLE, systemic lupus erythematosus, or lupus. And it's a condition that can cause rashes and can cause problems with kidneys and with the skin and joints as well. So we do see quite a lot of lupus, and we are the regional centre for lupus and connective tissue disease. So though it will be rare to, say, your general practitioner, they may only have 1 or 2 people on their books with lupus. Obviously, we see a lot of it. We have a weekly clinic for people with lupus. And then there's other conditions, Sjogren's syndrome, which is a condition that causes dryness in the eyes and the mouth and can also cause problems with arthritis and skin. Scleroderma, which is, again, very rare, but can cause problems with skin, kidneys, and lungs, and can cause this problem here, which is called Raynaud's phenomenon, which you may have heard of, or some of you may actually have, which is a problem of the circulation where I kind of describe it as, when you were young and you used to throw snowballs and your fingers went white cold and numb and then went red hot. So that is often a hallmark of connective tissue diseases. A lot of the words we use end in itis. That means inflammation. So myositis is inflammation of the muscles. So that's another autoimmune condition we look after. Antiphospholipid syndrome. You can see where our medical students struggle with rheumatology. Antiphospholipid syndrome is a condition probably best known as sticky blood syndrome. So various disorders of the immune system can make your blood a bit more sticky and easier to clot. And we have to use blood thinning treatment to help with that. And then other conditions, again, you're getting the hang of this, vasculitis, which is inflammation of the blood vessels. And of course, blood vessels go everywhere in your body, so it can affect any organ, but particularly, again, skin, kidneys, lung, brain. To a huge spectrum from fairly common and pretty mild conditions called polymyalgia rheumatica, which can cause inflammation, particularly in the muscles and the blood vessels in the head, to much more rare conditions, these funny things here called Wegener's and Churg-Strauss vasculitis, which are very, very rare, but when they come, they're very serious, and we need to get on top of it very quickly. And something we don't deal with quite so much these days, osteoporosis, which is thinning of the bones, again, more common in ladies after the change, because our GP colleagues are much more hot at dealing with this now, and there's a lot of very effective treatments to help with that. But in people with very severe osteoporosis, we often help with them, particularly with our bone unit, which is the endocrinologists. So we work with them to look after people with that. So moving on to treatments, and that's where the fun starts. So unfortunately, because we struggled a bit over the years to get effective treatments for rheumatological conditions, that's why when you pick up the Daily Express, as it seems to be every day, there's a new cure for arthritis. And my mother sends me them on a regular basis. And I have to tell her most of them, unfortunately, are a load of rubbish. But some of that, of course, is our fault because we haven't been really good at getting good treatments for people with arthritis. So if you're desperate, of course, you're going to think of anything and listen to the neighbour and so who said, this worked for me. So lots and lots of different things have been looked at. For all the what you would maybe call alternative therapies, there's very little evidence that any of them make any difference. Of course, there's this thing called placebo effect, which the brain is a really, really powerful organ. So if you want to be better and you take something and you think you're better, we don't know if it is that unless you do a proper research study. It may just be that it's just one of those things. So lots and lots of different things have been tried, but I'm afraid it's the rather slightly dull but reliable things that we still use to treat rheumatic conditions. So if people have joint pain or inflammation, it's painkillers and anti-inflammatories, steroid injections, which can be into the joint itself or into the bloodstream if it's a very severe inflammatory problem. And we very much rely on our colleagues in the therapies to help deal with things. And often people can, if nipped in the bud, have very effective therapy without having to escalate to more serious medicines. The good news, as we've got better at treating things like rheumatoid arthritis, is that we refer less and less to orthopaedic surgery these days. So in the old days, unfortunately, when we didn't have great treatments for rheumatoid arthritis, people got often very deformed joints and had to have a lot of surgery. It's vanishingly rare now, which is, again, even in my time as a rheumatologist, you know, when we speak to medical students now, you just don't see the joint deformities that you did even 10 years ago. So it's a really good news story. So the more serious conditions, which are disorders of the immune system, the medicines are really there to help regulate the part of the immune system that's gone a bit haywire, that's become a bit overactive. And steroids are still the mainstay of treatment because they help settle down the inflammation very rapidly when we have to get on top of the condition quickly. But we quickly move on to other drugs that help suppress the immune system in the long term and perhaps don't have the side effects that steroids in the long term could have. And I just put some drugs up there just in case any of you are familiar with rheumatology terms, but things like methotrexate, azathioprine, those kind of drugs are general what we call immunosuppressants that help regulate the immune system. But the new drugs that have come out more recently are these things called biological therapies. And why they're so good is because they target specific molecules, so they have a much more powerful effect on the condition with less side effects because they are targeting the molecule that's caused the inflammation in the system affected. And you might have heard of these things called anti-TNF drugs, of which there's a number 3 or 4 now. And these other drugs are other biological drugs that just target slightly different molecules that are all important in the immune system. So it's been a huge advance and it's great, but there is a downside to that in that they're very expensive. So to put people on these medicines costs between £8,000 and £10,000 a year. And obviously these are conditions that we can control, but we can't cure. So they tend to be on them for life. And so £10,000 a year for life is a lot of money. So there's a lot of debate and we have to be clearly very sensible and regulated about how we use these medicines. So we obviously only use them when we feel that it's going to benefit the patient, and we're constantly checking that they still need to be on the medicine. You've probably heard of NICE, which is a national organisation that has sort of told us what we can or what we should be doing, and we have to stick to those guidance and also based with our commissioners. But thankfully at the moment, there doesn't seem to be any problem getting the drugs if people need to get the drugs. If people have really severe disease, we almost treat these conditions like somebody with cancer, and we give small doses of chemotherapy as another way of regulating the immune system. So there's this medicine called cyclophosphamide, which people get for cancer treatments, but we also use in our conditions. So that's just a little bit about the conditions itself. I don't know, I'm going to now talk a little bit about the research we're doing at Leeds. I don't know if anyone wants to ask any questions now or, yeah.
In view of the cost of biologics, are there any plans to introduce biosimilar drugs?
Yeah, and just was at a meeting this afternoon about biosimilars, so that's been talked about for a while. I haven't seen any appearing in rheumatology yet. So the question was, are we going to use biosimilars? So biosimilars are essentially looking at targeting the same molecule, but made in a slightly different way and hopefully cheaper. So essentially bringing in a bit of market competition. So there's been a lot of talk about this, but at the moment we haven't got any that have approached us in the UK to start introducing, but I'm sure it will only be a matter of time. The latest evidence suggests that there is no difference clinically, because obviously the first thing we worry about is, are they as effective as the drugs, you know, that were made by the company initially? But the first lot of research studies suggest that they're just as good. So clearly if they're as good and they're cheaper, we will be switching over to them. Okay, I'll move on to research, because obviously that's a really big part of what we do in rheumatology in Leeds. So there's this thing called the National Institute for Health Research, NIHR, which essentially is the research arm of the NHS. So it was commenced about 10 years ago now by the government to say we really want to put a strong incentive to do research in the NHS because we know it's better for patients, it's better for outcomes. So they formed this thing called the NIHR, and they have various sites around the UK funded by the NIHR. And we in Leeds are the Leeds Musculoskeletal Biomedical Research Unit, LMBRU. And we've had that since 2008. We're very proud of it. It's the only NIHR biomedical research unit, not only in Leeds, but also in Yorkshire. And so we were funded on the basis of all the work that we've done over the last 10 to 20 years. And it's a partnership between the Trust and the University of Leeds. We work really closely together. You can see even at the consultant level, some of us are university employed, some of us are NHS employed. And really you couldn't tell on a day-to-day basis who was who. And so I think there's 3 musculoskeletal biomedical research units in the UK, and our remit is around the things obviously that we do well, which is looking at things like rheumatoid arthritis, the use of imaging, and also we have a big bioengineering unit at the university as well. So there's lots of work going on there about prosthesis and regeneration too. There's also other research facilities. This is other thing called the Clinical Research Facility, which we're part of, and that's a bit more experimental. So obviously what happens in research is that early work is done, and then it's tested in volunteers, and then it's tested in patients, and then it's tested in a bigger way. Well, the Clinical Research Facility is very much more the experimental end, and the Biomedical Research Unit is perhaps drugs or imaging that's already been tested in volunteers, and we roll it out into our patients. So we're a big imaging centre at Chapel Allerton. We have a state-of-the-art MRI scanner, and we have a specially built MRI scanner that can take people with musculoskeletal problems. So I don't know if any of you have been in an MRI. Usually they're really quite enclosed and claustrophobic. I'm in it all the time for doing research. I hate it. But ours is quite big. So we have a wide aperture to make it just feel a little bit easier. And we work very closely with our radiologists to have a whole program of work in MRI. We also use a lot of joint ultrasound, and again, we use that in our research purposes. So what are we known for in Leeds? Well, our most probably biggest thing we're known for in Leeds is finding out about biological agents. So there was really 2 big centres that discovered biologics, Imperial College in London and Leeds. And most of the early work was done by Paul Emery and his team looking at biologics and translating it into patients. We're also, in the last sort of 5 years or so, really focusing on how do we diagnose things like rheumatoid arthritis early, because the problem we have with a lot of our conditions is there's not one specific test that we can do to diagnose the condition. There's not a blood test like diabetes or a scan like heart disease. It's based on what the patients tell us and clinical examination. So we're doing quite a lot of work to look at various biomarkers, blood tests, to try and identify people very early on whether they have the condition and also how serious it's going to be. And we also...
Yep. Please. I've got arthritis. CRP then, where is that?
Yeah, so CRP, C-reactive protein, is a marker of inflammation. So it's helpful for us to let us know how active your arthritis is, but it's not specific for arthritis.
So if I tell you I had 102.5 reading, is that bad?
Well, that's high for somebody with arthritis, but the problem with CRP is if you have other conditions, it can be high too. So if somebody's got an infection, say they've got a bad chest infection, their CRP will be high too. So it's helpful once you've made the diagnosis to let you know how active the arthritis is, but it wouldn't diagnose arthritis. What we're looking at is specific tests that say, have you got rheumatoid arthritis? 100% yes or no, that kind of thing.
Do you still use the ESR test?
Yeah, and that's very similar to the CRP. So they measure much the same thing, CRP, because it's more specific. So ESR is quite an old-fashioned test, and probably CRP gives you a little bit more inflammation. But again, it doesn't cause the diagnosis. So a lot of imaging, and more recently, we're also quite well known for connective tissue disease and vasculitis. So not just the arthritis, this is more of the things like lupus, and the way in the UK how they manage what we call specialist services has changed recently. So they've realised that in rare diseases it's best to group them in centres that have expertise, and create a network around the region for other centres. So Leeds is the network centre for rare diseases, autoimmune diseases. So though we work very closely with our colleagues in the district general hospitals, most patients will pass through us now. So just to end on a few examples of what we do. So as I say, we're a big imaging unit. And this, just to show how fast things have moved on, this was the first MRI in a human. That's a finger, you would never know, but apparently it is, in 1977. Oh, I'm a bit wonky. And this is an MRI now from our research unit. And this is called quantitative MRI. So this is where we actually can look completely at 3D anatomy of a joint. So we've put somebody in the MRI scanner, and you do fancy digital extraction to take away all the background stuff. And you can actually see this is a knee joint, that you can see the joint itself, and you can see these areas here are the areas being damaged by arthritis. So we've come a long way. Oh, it's gone a bit wonky, but there we are. So this is another MRI. So MRI not only tells you about the structure of joints, you can also look to see the blood vessels of joints. So these are just cut through the knuckles of a hand, and this is a normal joint where you can see the bone, and you can see a little bit of orangey red. That's the blood vessels. And this is the fingers of somebody with active rheumatoid arthritis, and you can see the blood vessels are significantly raised and expanded because of the extra inflammation around the joint.
Do you ever use a CT scanner in rheumatology?
So we do use CT scans, but the downside of CT scans is there's radiation. The beauty of MRI is there's no radiation to the patient. So CT has some advantages in certain situations, but we try and avoid CT because it means like X-ray radiation. So this is my colleague Dennis McGonigal, and this is something called a nano PET scanner. So like MRI, this is another type of scanner that looks right down at the cellular level in joints. And this is, again, a finger joint, where this is the MRI of the finger joint, and you can see the bones and the cartilage and the tendons. And then what we do is inject a certain tracer into the blood vessel that's taken up by inflamed tissue. And here you can see that this is a very inflamed joint because it's red and orange, and that's the tracer moving to the part of the body that's inflamed and showing us how active the disease. So I guess it's space-age CRP. So where CRP kind of tells us there's some inflammation somewhere, this scan tells us exactly where the inflammation is, and more importantly now is telling us when we use medicines, how effective are we being if we do a scan before, and then we give the medicine, we do the scan after, have we got rid of all the inflammation? So hopefully you can tell that I'm passionate about research. I think it's absolutely the way as a teaching hospital, and the clue is in our title, Leeds Teaching Hospital, that we need to be involved in research, because we know that organisations who take part in research have better outcomes for their patients. We know financially it's a good thing to do. And we know that particularly in Yorkshire, it's a really important thing for us, for the economy. Places like Cambridge have absolutely revolutionised the way they've had their local economy by sort of developing a technology part of their service. And there's a big drive for Yorkshire to try and encourage more what we call life science industry to Yorkshire. So we have a very active and really helpful patient and public support group at Chapel Allerton, particularly through LMBRU, our research arm, which we've had since 2009. We've got more than 120 members. And they're really with us all the way in developing research protocols, because we need to know what the questions that are important to patients are. There's no point doing research if it's completely irrelevant to people. So it's been really helpful to know what questions do people want answered, what the likelihood of people taking part in that kind of research is, and obviously helping with sharing the results afterwards. So as I say, we have an active meeting, and we've actually got one this Wednesday, which is, I think this one's about hip research. And there's some contact details there if anyone is interested in being part of it. You may already be part of PPI groups. You know, within the hospital there's a number running. I'm sure we can provide information. And that's it. So, any questions?